Okay, thank you to CVI for the opportunity to speak today. I have no disclosures. So our objectives today will include a brief summary of proper patient selection. The bulk will be regarding the procedure types. Given the time, I will be focusing on forefoot offloading procedures, and major reconstruction and tendon rebalancing we'll have to save for another day. I'll be reviewing the literature along the way. Just a disclaimer, the available literature is of small patient populations and retrospective case series, but the comparative papers and RCTs I have included here. So proper patient selection is paramount, and as with any patient that has a foot wound, whether they're going to undergo surgery or not, sufficient perfusion is required. So the goals of surgery, well, we're talking about this to get wounds healed, and why? Because we want to prevent amputation and the increased mortality that comes along with it. So understanding that this is a structural deformity, and if we walk it back, that had formed for multifactorial reasons, polyneuropathy being a major causative factor, sensory, motor, and autonomic dysfunction, leading to muscular atrophy and limited joint mobility, and a deformity like you see here with a prominent metatarsal head. So if we address this, we can address the wound. So does surgery work for healing diabetic foot ulcers? As you can see here, this surgical group had significantly improved outcomes in regards to much higher healing rates, less time to healing, less infection, and less recurrence. So what are these procedures that I'm alluding to? Well, the patients that are going to get these are going to be patients with wounds due to a stiff big toe, lesser toe contractures, or ulcers under the metatarsal heads, and then we will lastly talk about equinus that drives some of these ulcer patterns. So this patient had a wound under his hallux IPJ. You'll typically see arthritis at the first MTP joint, and a Keller arthroplasty, where you resect the base of the proximal phalanx of the hallux, allows for more joint mobility there and less strain and shear forces on the soft tissue there to allow for healing. This was 6 weeks out, excuse me. So Lynn looked at patients getting the quote-unquote gold standard for non-operative care, a total contact cast versus the Keller, and found significant improved healing and outcomes with the surgical operation. Armstrong did the same in a little larger group. He noted significantly less time to healing in the Keller arthroplasty group, almost quadruple the time versus patients that did not have the operation. So what about a lesser toe contracture? I apologize, I don't have a clinical picture here, but very common to see. The mainstay is ellipsing of the wound, resection of bone underneath, similar to the hallux rigidus, and pinning. So Armstrong and Lavery had a group of patients, both diabetic and non-diabetic, with rigid hammer toe contractures. They had positive outcomes that, regardless of diabetes or not. The diabetic group had a subgroup with an ulcer that about 14% did develop an infection. So patients with a flexible toe contracture can undergo a tenotomy. This can be done in the office. We do these quite frequently. And this is, I stole this from Dr. Tammer's paper in 2014, but you can see how quickly those can heal. A recent systematic review showed the positive outcomes from this operation. So I'll kind of briefly go through metatarsal ulcers. You can perform a single metatarsal head resection, positive outcomes, or a multiple metatarsal head resection. This was a patient at a year out, had healed up quite nicely. And then another Armstrong paper that had a comparative group of non-op care with, again, better times to healing, less recurrence, less infection, and less amputation, although not significant in this group statistically. So lastly, I want to address a major contributing factor in forefoot ulcers, that equinus. So a normal foot, the Achilles tendon is not contracted and you don't get driving force down into the forefoot. But in chronic equinus, you see it's pulling up on the heel. You get increased plantar pressures from the forefoot being driven into the ground. So addressing this is commonly done with the tendo-Achilles lengthening versus a gastroc. You can do it a percutaneous approach. And then this was studied by a classic paper by Dr. Mueller, and they compared total contact casting in both groups, but the surgical group received tendo-Achilles lengthening, and their forefoot ulcers were healed, all of them healed in 7 months versus just 88%, which is a sufficient group. But the main takeaway here is at 2 years, the patients who received the TAL had a significantly less recurrence rate, and so that is a paramount paper there. So in summary, surgery for these patients' forefoot wounds, you address the biomechanical etiology, and looking at the literature, you get a high prevalence of healing and less recurrence, and ultimately that limb salvage that reduces amputation. So with that, I'll leave you with a quote from a pioneer or a thought leader, if you will, Paul Brand, who developed the total contact cast, actually for patients with leprosy, but nonetheless has been able to be carried over to insensate feet with diabetes. And he understood that the whole problem is not really one of medicine, but more so of mechanics. So if we can understand that, we can address these wounds. With that, I thank you for your attention.